Thank you very much for your kind introduction, and thank you very much, Dr. Bimsara, for inviting me for this lecture. Good afternoon, everyone. So we are going to talk about the concepts of cervical screening. I have no disclosures, and this message is from NHS UK. The message is quite clear and strong. It says that my mom missed her smear test, now I miss my mom. So we see lots of young women and having the cervical cancer and with the unfortunate deaths. Out of all the gynecological malignancies that I deal with, mainly ovarian cancer, we don't have any pre-malignant state and there's no screening test. Endometrial cancer, we have a pre-malignant state, but there's no screening. Cervical cancer, we have a pre-malignant state, we have a screening test, but we see this kind of young children losing their moms, which is quite unfortunate. Look at this young girl and see what happened to her in a couple of months' time. These are horrible deaths. The cervical cancer deaths are horrible deaths. They are not immediate deaths like a myocardial infarction. I'm sure everyone must have seen at least one cervical cancer death in their career. So they are bleeding, they are having a severe back pain, they are fistulating, they are leaking feces, urine, and immediately transform this young woman into this poor, wretched state. Of course, the 19-year-old is very unusual, but still we see lots of young women having these unfortunate deaths. So the picture is pretty different because in developed world, we see there's a drastic reduction of number of cervical cancer cases. Now you can see the top diagram in the United States and the Netherlands, and the below diagram from the Australia statistics. This, we have observed there's the number of cases are decreased over the time. Of course, they have enough resources. While we are crowded with all these clinics and busy, and we are having a high number of cases reported every year. These red and orange lines are showing the low and middle income countries, while the lower lines are showing the high and very high income countries. It's not just the patient factors where the knowledge is the barrier or the cultural beliefs, but of course we need lots of resources and training staff and the cost and the funding from the institutional factors. When it comes to the situation of the Sri Lanka, the cervical cancer is the commonest gynecological malignancy. Next to the breast cancers, this is the commonest cancer we see every year. Unfortunately, the incidence are rising. When I was a registrar, I learned that the number of cases is like 1,200 per year, but now it is more than 1,500 per year. This is the 2023 HPV Center World data. And I'm going to talk about what are the risk factors, which is HPV. Now, in our population, it's about 4.4% harbor the high-risk HPV. That means roughly 1 in 20 women will have this high-risk HPV. Unfortunately, although they are harboring 1 in 20 women in this crowd probably, but the uptake of this screening program in Sri Lanka is less than 30%, which is quite unfortunate. So why we have to have this screening program? This is screening program in general is to catch somebody asymptomatic, and they are developing a high risk or developing a specific disorder, and which warrants investigation or some particular action. So that is why we are having this screening program in general. Of course, to meet this criteria for screening, the disease should be an important health issue, and the disease should have a natural history, and there should be a disease marker in a latent period of the early symptomatic stage. Of course, cervical cancer fulfill all three criteria as I mentioned. And what test, the test that we are using for the screening should be acceptable by the population. And also it has to have an effective treatment, and which makes the difference in when it comes to the outcome. And of course, we have a policy, and also the policy covers the individual which are going to be offered. So cervical cancer fulfills this universal criteria for the disease specific factors as well as the test specific factors. Sorry. Okay, thank you. So the human papilloma virus is the cause for the HPV, and which is more than 99% of cases the culprit is the HPV. Now out of the about hundreds of strains, now the International Agency for Research and Cancer, IARC, found out that about 12 are carcinogenic and one is a probable carcinogen. Mostly it's the 16 and 18 are the reason for most of the cervical cancers. Now, what happens in the cervical cancer, once the HPV is infected the epithelium of the cervix through a breach, and then it infects through this parabasal layer and these squamous cells in the cervix, and then it goes through the whole layer, and then finally it invades the basement membrane and become a cervical cancer. Oh, sorry, no problem. So once the cervix is infected with the human papilloma virus, it takes time to proliferate, so we cause a productive infection, and then later on this virus, the genome is incorporated into the cervical cells, and then it transforms into the malignancy, which is a complex mechanism. But important message is that it takes time, but majority of these high-risk HPV will clear from your body with your immunity. But essentially you need to have a screening to catch that whether it is transforming into the malignancy with time. But most of the cancers, or especially the CIN, that means a cervical intraepithelial neoplasia, with time cleared from the body. Now, how to screen? Now, there are ways that we can screen. Now, either we can look through our naked eye, we call the visual inspection, or the better sophisticated way, we can get some cells and look into the microscope and having the cytological analysis, which we usually do by the conventional pap smear, or get these cells in some liquid and see whether the cells showing any abnormality, which is a liquid based cytology. Or put these cells and put some special staining called P16 and KR67 and see whether they are showing any changes that are the effect from the HPV. Going into the further details of the molecular level, so we can either see whether the nucleic acids or the DNA or the protein biomarkers are showing any changes that are related to the human papilloma virus. Of course, all these methods are happening in all around the world and different parts using the different techniques. Now, the pap smear what we commonly use having the sensitivity of 53%, but it's more specific. I'm going to discuss others in short time. Compared to around our region, now the Sri Lanka, which has initiated most the national guidelines in 1998, and we use this as cytology screening, and most of our countries, other countries, using this visual inspection with acetic acid and see whether there's any abnormality as a primary screening for the cervical cancer. Conventionally, as I told, there are three usually the instruments we can take the smears from the cervix, namely this IS spatula, which you can see from your left, and then the endocervical brush and the cervical broom. So these cells are taken through either of these instruments and smear and stain and see whether they are showing any abnormality. Other option is like we can get these cells into this special liquid and then transform into this thin film and see whether there are any abnormalities. The good thing is that when we take this technique, the abnormalities from the blood cells, pus and mucus will be taken away, and we can see whether there is abnormality. And we usually look into the HPV DNA. So if we detect any abnormality, we can look back to the cells and see whether there are cell changes are there. Although we look and think that the HPV DNA is a very costly, but the cytology also is quite costly, because for the training and the sample takers, the cytoscreeners and the cytopathologists, and the workload is quite a lot. And also this also requires quite a lot of manpower and takes a lots of resources than we think. And also we need to have a good quality assurance because it's a primary screening. The visual inspection with acetic acid, commonly used in India, also is just looking at the cervix and see whether there's abnormality. Of course, some Indian studies have shown that there's a reduction in cervical cancer incidence and the mortality rates. As is shown, this picture, that's what we see with the acetic acid, but our eyes need to have a good precision to detect which is abnormal and which is not. I'm pretty sure that it's very difficult to differentiate which is CIN1 and CIN2 and CIN3 to an untrained person. The HPV DNA, which is available in United Kingdom and most of the countries, contrast to initial figures. Now it has more sensitivity and specificity, which almost reaches to the 100%. And it can detect most of these high risk strains, and also they are able to detect what genotype, whether it's HPV 16 and 18 by the same specimen. Now when it comes to the low cost or limited resource settings, now this American company, they have invented this care HPV testing. Although the initial cost is quite a lot, but after that we can do a testing, and the result will come in like a 2.5 hours time, and we can simultaneously test about 96 patients, and for then per one patient the cost would be about $5. So that is why some of the argument comes that although the initial cost is more, but if we could implement, the follow-ups can be done easily, as well as the later on the cost could be minimized if we implement HPV DNA in contrast to the cytology. Some of the rural areas in India, they have tried whether we could do the urine testing in contrast to this, because of the social stigma and these cultural beliefs. So the patient collect her urine sample and come and bring and see whether they are having the cervical cancer. Of course, it has a low sensitivity but fairly specific in terms of cervical cancer. Now, how are we going to screen? Now, when we formulated this national guideline in 2021, we saw lots of young women has been discouraged, don't come, you don't have cervical cancer, come at age of 35, but we have operated number of cervical cancer patients age of 20s, late 20s, because they've been sexually active very young age. Now the literature says once you acquire the HPV, it takes about 3 to 7 years to get a full-blown cancer. So that's the argument in United Kingdom or the Americans, where the screening invitation comes in either age of 21 or 24 and a half. Then they believe that okay, we'll be able to catch the most of the patients before they come to the full-blown cancer. So that is why we suggested that the national screening should come to the age of 30 in contrast to the age of 35. And also if the patient demands, that patient wants to have a screening, and if they are after the 3 years following their sexual debut, do not discourage them, let them to have a screening, because that can prevent to have another cervical cancer. So we recommend that them to have at least 10 yearly screening. That means if you start on age of 30, let's say that patient will end by the screening by 60, it's a 4 test in her lifetime. That's fairly reasonable. And if she has a high risk factors, of course you can have a 5 yearly follow-up. That's much cost effective, which I'm going to talk later on, than we treat a cervical cancer. So the high risk patients are namely, so if the patient is having a multiple sexual partners, or smoker, age above 40 years and ever been sexually active, or somebody who is sexually active at very young age, multiparity or low socioeconomic status, and has not been screened for cervical cancer, or other STDs like chlamydia, gonorrhea, herpes, or HIV, or immunodeficient. And also if the patient had a previously abnormal smears, also we call them a high risk patients, and which warrants them to have a 5-yearly smears. Now, if they are taking some immunomodulators, or if they are following organ transplant, but if they don't have abnormalities before smears, they can follow the normal smears. Other important thing is, if the patient is on a same-sex relationship, we don't know about the partners, so history. So if they have a cervix, although she is in a same-sex relationship, if she fit into our national guidelines, she should have the cervical screening. So this is from the national guideline from the cervical cancer. So all these things are quite comprehensive. So if we have the HPV, you can go through the HPV pathways, or what we commonly do, the cervical cytology, then this is the algorithm which we need to follow. Important message is, if the smear comes as unsatisfactory, then don't repeat in month's time. Repeat in at least, give it the cervical epithelium regenerate, and repeat in 3 months time. Importantly, if there's no abnormality, she can go to the normal. If it is ascus low grade, that means atypical squamous cells of undetermined significance with a low grade, or low grade squamous intraepithelial lesion, then you can repeat the smears in 6 months time. All others, either colposcopy or refer. So simple terms. So these guidelines are freely available in internet. Okay. And when it comes to the evolution, so Dr. George Papanicolaou invented this cervical screening in 1928. Now it's almost a century, but still we are stuck into the cervical pap smear. And the team has validated in 1940s whether we could do this in the primary screening setting. And it took another 10 years to the world to accept that we can do it in a global setting. And another 30 years it took that the world to realize that, okay, the HPV is the cause, and Dr. Hausen won the Nobel Prize for the HPV as a causative for the cervical cancer. And in mid-90s, the HPV subtypes and the persistence of this infection has found out there's a cause for the cervical cancer. So are we still believing or thinking of the cervical cancer in another year? No. Of course, the world has progressed, because the innovative thinkers now think that this circulating tumor DNA, so that means when the cervical cancer tumor, so they exfoliate the cancer cells and go into your bloodstream, and then what if we detect these fragments of this DNA from your cells? Of course, this derived from the head and neck cancers that's related to the HPV, and they have some promising results with the applicability in the cervical cancers. So the future is here. So maybe in a few years' time, we might see, rather than doing the cervical smear, we might go into the circulating tumor DNA in the patients. Of course, they have checked this in the vaginal smears as well as the urine samples, but the plasma showing not promising results. But of course, they have detected circulating tumor DNA cells in 76% of high-grade abnormalities in the cervix, which has not turned out to be a cancer. Now, these studies are not too old, but a couple of years back. Now, the Chinese people are doing some microRNAs, and whether they are predictable in terms of cervical cancer. So in future, we might see some of the diagnostic tests coming and checking your blood and say, okay, you are having a cervical cancer in this year's times and all. There's another aspect that we don't normally touch on this cervical cancer screening. That's the cost analysis of the cervical cancer treatment. This is an important study that is carried out in the Americans a couple of years back. Now this LOT stands for the line of therapy or the treatment. Now these Americans have evaluated how much cost each cancer patient carries. So the primary analysis would be let it be the surgery. That means the surgery, planning, MRI, PET scanning, and their traveling and the parking and hospital cost and everything. Or it could be the external beam radiotherapy or brachytherapy or whatever. So their analysis has shown the one patient per month, the cost is more than 10,000 US dollars. So if we convert that money, it's a 31 lakh per patient per month. Are we able to afford this money? Of course, we don't do MRI for each and every patient, but the patient could do a cervical smear even at private sector less than 10,000 rupees. So this 31 lakhs will come not just from the patient, it comes from my pocket as well as all other gentlemen's pockets from as well. So it is the patient's responsibility to have the pap smear so that we can stop this much of wastage of money if they have a cervical smear on the time. So what's the barrier? Do we think that the patients are unaware or the staff is unaware? So I did this study when I was a registrar in a preliminary hospital in Matale. So I did because our gynec staff, we see that a lot of patients having cervical cancer, and they are educated, of course. So it's a basic study of the 91 staff members, most are nurses and the doctors. Surprisingly, 51% of the people have not had a cervical smear in their lifetime. So I'm not surprised if we replicate this study in the other hospital also. That means the patients, our crowd also might be have the similar results. I don't know how many in this crowd had the cervical smear. So could we do anything to raise the awareness? It's not just the awareness. I mean, the IGCS, International Gynecological Cancer Society, one of the leading most gynec cancer societies. So they have checked like how many Facebook and the social media tweets to increase the awareness. Of course, cervical cancer, there are lots of mentions, but still people are not quite keen on doing the cervical cancer for some reason. This interesting actress and done some her social media saying that she is passed away due to cervical cancer. Then everyone thought about, okay, because of her character and all, okay, and then later on she said that, okay, I post this thing just because to raise the awareness. People are doing these various funny things also just to make the awareness and can cause the cervical cancer awareness and to reduce at least the mortality and the morbidity by their level. Now, the WHO, have the targets by 2030 to, we call it a 90-70-90 initiative. It's a simple terms. So starting from a girl who is at the 15 years of age to have vaccinated at least 90% of the crowd. And once she reached the reproductive age, so 70% of the women to have this high quality screening by at least age of 35 and then 45 two cohorts. The 35 and 45 comes from the WHO because it's not just for the Sri Lankan population, it covers all the sub-Saharan countries in the Africa and the whole world. But at least they think, at least if you have the 70% of screening coverage by the crowd, by at least 2 times in their lifetime, can reduce the cervical cancer burden. And also 90% of the women who are diagnosed with cervical cancer to have the treatment, because we see lots and lots of women are not having adequate treatment and ultimately ended up under my care or the oncologist ward not being suitable for any sort of a treatment. So to take home message now, even if you forget about all this fancy stuff, but remember now cervical cancer, the cancer incidences are rising every year. So this is an easily preventable death. So, and also do not discourage if someone wants to have a screening, and please let them have it, and because we don't know what happened on their side of the story. And as I told, it's a responsibility as well because it's everybody's money. And if you haven't had the pap smear, please go and have it. I'm sure Dr. Beam sir will accommodate. And every day there are 2 deaths are reported from the cervical cancer. So get the message, please have a screening. That's all. Thank you very much.